Again, good afternoon to everybody. It's very exciting to be here because I have to say, if this is what we are heading in the next 2 days, it's going to be a full fun. My name is Nir Uriel. I'm from Columbia University and Cornell University, and together with me here is Dr. Eddie Rami from Temple University, and we have a very distinguished panel that actually is here with us today, and we will introduce them as we're going along, because we want to start kicking up and when people will give some comment. So the coming session is going to be a pitfall in assessment cardiogenic shock severity. And I have to say it's with great honor to introduce the first speaker, Dr. David Baran. Dr. David Baran, first of all, is a close friend, is right now running the program in Sentara, heading to a new adventure in Florida, next to the coast. And David is, of course, one of the leaders in the new classification, and nobody better than him to speak about these pitfalls. So, David.
Hi, Ashrit.
Thank you, Nir, and thank you to the Dr. Jamin and everybody. It's truly an honor and pleasure to be here today to talk to you about the pitfalls of cardiogenic shock severity. And I would say that this is a topic that was a very interesting title, and hopefully I'll do it justice. My disclosures are here. I've worked with a variety of the device companies. The slides are mine. So when you think of pitfall and you go back, I guess I have to show my age. I remember when this came out and, pitfall, and if you look at this picture, you see the person's trying to go over a lake with alligators, and that really is as useful as it was back then, still now, because isn't that all of our jobs? We are constantly the man on the rope trying to escape from the predators that are trying to take us over. And I will tell you about a few key aspects. So first, pitfalls of mixed shock, normotensive shock, what to do with staging of severity with patients who already have hemodynamics after the treatment has started, chronic heart failure shock, and the dissociation between the therapy and the shock severity, some hazardous transportation. So that's an outline. But I thought that I would start with actually a clinical case of somebody that we saw recently. A 33-year-old woman presents to the emergency room with some abdominal pain, a bit of dysuria, ho-hum, straightforward, a little bit hypotensive, perhaps dehydrated, gets some fluid, has a clear diagnosis of a UTI, and gets sent home after a liter or two of fluid with some ceftriaxone and a script for an antibiotic. That should be very straightforward, but like always in medicine, the beauty is that if we don't get it right the first time, the patients give us more and more chances, and indeed she did. 24 hours later, comes back, nauseated, abdominal pain. Now she can't tolerate anything by mouth at all. A bit hypotensive, a bit tachycardic. She would clearly be described as a SCAI B, but they weren't really thinking of that in the ER. With diffuse abdominal tenderness, looks really lousy, and somebody measured a lactic acid for some reason, which was 6.6. White count was quite high. In her data, EKG, not really showing too much, but the money is in her CT, and they said, okay, now we got the answer. It's not a UTI, it's a cholecystitis. X-ray doesn't look too exciting. She was moved to the ICU and now still hypotensive despite lots of hydration. It's otherwise a young, healthy person. Now they added norepinephrine because I guess they read the papers that that's the preferred pressor. The CT scan seemed to explain it, so they called general surgery. And while they were waiting for general surgery to come, the patient unfortunately continued to rapidly spiral down. And 2 hours after she came back that second time to the ER, she actually had a cardiac arrest. It was PA, and because they were very lucky, a young person, they got her back after 20 minutes. And at that point, general surgery was on the scene. They literally got ROSC. After 10 minutes, took her to an open OR, and they thought that she must have abdominal compartment syndrome or sepsis, something of this sort. But intraoperatively, although there was an edematous gallbladder, it wasn't particularly exciting. They didn't see dead bowel, took out some fluid. And they thought, all right, well, now maybe this is okay. She had a Thera dressing on the belly. But things still were not getting better. It went back to the ICU, continuing to spiral out of control, bad to more than bad and worse. Neuric, lactic acidosis. They finally, almost as a desperate moment, the medical ICU, which rarely called the shock team. And myself and my colleagues ran over to the other building where they were. And this is not a moving picture, but basically just showing you intubated young woman. The LV was fine. The RV looked very bad. At this point, she had a map of 30 to 35 on 4 pressors. However, the very funny thing is that she was very warm, extremities well seemed well perfused with bounding pulses, and yet she was on wide open everything with a map of 30. And so FSCAI, well, is this cardiogenic shock? Is this septic shock? Is it just RV failure? Did she have a pulmonary embolism? Nothing really fitting together, and literally we're all at the bedside trying to figure out what to do for this bad mojo. And it just shows that sometimes things are not as clear as they seem. When they call you, it's not so clear if it's cardiogenic shock or septic shock or what do you do with it. And interesting in this case, which we wrote up, Ashley decided to just put the patient on ECMO. Certainly we had debates, is that going to be the right move? Is she going to even be able to flow from ECMO because she's maybe vasodilated? But interestingly, we saved this lady with emergent VA ECMO, and then were able to have calmer heads once she was more stable. Turned out that this lady had what you see in the top left. She actually had history that which she had not obtained, that she had a complicated pregnancy 4 years prior and hemorrhage at the time of delivery, which led to a empty cella. She had no ACTH, and once we managed her with steroids, she actually recovered and still remains fine now 2 years later. So that leads me then to talk about the various pitfalls, mixed up shock. Remember that a lot of times patients will present with fever, elevated white count, and so forth, even if it's a purely cardiac reason, and we can call it hemometabolic, hepatometabolic, whatever you want to call it. We've all seen these patients where they've gone beyond the initial insult to something else. The hemodynamics oftentimes on the worst of the worst are not available. You can imagine a case like this, they weren't going to place a swan when the patient has a map of 30 and 10 doctors in the room and trying to decide what to do. How do you assess cases like this? And so Jake Genser wrote this very nice paper that was published very recently looking at shock severity, and the idea was that we developed a SCAI shock for cardiogenic shock. And I'll direct you to the full paper in the interest of time, but basically he showed that on the top you have the SOFA score, and looking at SOFA score certainly predicts mortality, has a cardiovascular component. So does SCAI shock score, much like you use it with blood pressure, heart rate, and so forth, and indices of perfusion. And on the bottom left, you can see that SCAI shock in a ICU mixed population, not all just cardiogenic, actually predicted survival really well, suggesting there's more alike between general ICU patients with or without a cardiac etiology. What about other interesting things? So this is really nice work from the guys from Culprit Shock, where they looked at microvasculature by using microscopy in the microvessels under the tongue. And these graphs just show that it's not as simple as it seems. It's not just mean arterial pressure or systolic blood pressure. What's really important is perfusion, and I certainly hats off to folks who can take patients in shock and look at microvasculature. But what this is showing is that whether it's proportion of perfused capillaries or capillary density, that's what actually predicted mortality, less so the degree of blood pressure. And that maybe explains why sometimes the things that are easy to measure are not necessarily the things with the greatest value. And then another paper from Dr. Genser, and this was shown just immediately previously by Dr. Van Diepen, but just looking at simple things like the criteria for hypotension or hyperperfusion. As you go with worse, the mortality rises. What about the challenge of the patient who comes to you with the hemodynamics measured after the treatment has begun? This is a very common problem, especially with the hub and spoke model, because inotropes and other things do work. So a patient comes over, they tell you this person's terribly ill, they do X, Y, or Z, they put them on some inotropes, and they come to you looking perfectly fine. Are they really fine? And if so, since you don't know what they started out as, do you believe that they were really terribly ill before, 0.2 of milrinone? Or, for example, the patient comes on an Impella and looks perfectly fine and wants you to change the channel so they can watch the sports game. Well, unless you really know what they looked like before, how do you know what stage they are? They look perfectly well perfused, or maybe they're on a device that nobody seems to like, but they still have quite an affection for a balloon pump, and they may still be fine. What about the whole issue of AHF or chronic shock? So I think this is really, really an important aspect, that the hemodynamics define shock. That's how we all look at things. What is the cardiac index? But if you're in the cath lab a lot, you certainly have seen patients who are ambulatory. I've seen one right before I came to this meeting with ejection fraction of 10%. a wedge of 35, mixed venous was 38%, index is terrible, and the patient's laying there quite comfortably listening to the music I usually have playing in the cath lab, and you would have no idea. So are they in shock? Yeah, the index is 1.5, but the patient's perfusing quite well, is holding a conversation. And so it's that mismatch that makes it challenging, that you can't just look at one thing. Chronicity and adaptation are quite important though, right? So we all imagine the reason that patient is comfortable and chatting away, laying flat, is because his wedge has been high for a long period of time. And what we don't understand in cardiogenic shock is all those compensatory mechanisms versus the executive that was fine until the LAD closed and now with a modest infarct is in severe shock. This is actually just a nice review paper that's from Circ heart failure with PV loops. As you've heard, lots of PV loops this morning, but the point being that there's biologic basis for understanding that the patient who's chronically in a different place on the Frank-Starling mechanism may respond differently to things such as intra-aortic balloon pump. And that explains the discrepancy. You know, as they say in Europe, supposedly nobody wants to use a balloon pump, but somehow they still work. And certainly this kind of thing explains that maybe a role for a device such as that with a lower type of flow might be in patients with chronic heart failure or SCAI-B, maybe. What about the dissociation between therapy and shock severity? And so, this is interesting from the cardiogenic shock working group. A very simple way, a lot of the validations of the SCAI shock criteria have been ways to retrospectively take a data set that was retrospectively generated and assign SCAI stages to it. And so this looks quite easy. Number of pressors, number of devices, and that tells you whether they're C or B or D or so forth. But in the real world, it's not that simple. So what do you do if a patient just comes with one device and one drip? That doesn't necessarily mean that they're SCAI-D, especially if they're improving quite well. And so we don't practice in the retrospect, we practice in prospective. And I would say, we have a prospective paper that we did with the center at Sentara showing that prospective assessment of SCAI stage is simple and it's prognostic. And this graph shows you that you can see, based on the improvement in SCAI stage, if a patient is either not changing in SCAI stage, which is green, or they're worsening, they're in trouble. And if they're improving by one or more SCAI stages, their actually mortality is much less. And this was nothing fancy. This is the groupthink of our shock team assessing a prospective stage and seeing what happens. What about the problem we're all familiar with is hazardous transportation? And my hat's off to Dr. Wald and the others that are starting a mobile ECMO team. We did one years ago when I was in Newark. It's very challenging. I thought this would be apropos the ad. This was for the people to go to the South Pole in the early 1900s. Men wanted for hazardous journey. Small wages, bitter cold, long months of complete darkness, constant danger, safe return doubtful, honor and recognition in case of success. Now that actually worked. And is that not our same description if you ask people to be on the shock team? Maybe only a little bit better than this job description. Perhaps the compensation is improved, but the hazards are there, and it's always in the middle of the night. It's usually on a holiday. So you get the patient in the ambulance and move them over, and the middle picture is to describe the salad spinner that must exist inside that ambulance because the patient that was otherwise okay comes to you, and you look at it and say, what in the world happened? Between the impeller falling out of position, the ET tube is clogged, the drips are all wrong, because it's hard to actually put them into an ambulance. It seems simple. I've gone on many ambulance transports, and it is not a simple place to be. The monitoring is very limited, and oftentimes the pumps don't work as well, the transport vent, and you get what you see on the bottom right. You sort of pull it out and you try to put the patient back together again. So the transport and shock is like this example from Forrest Gump, that the life is like a box of chocolates. The patient you're promised is oftentimes not the one that actually arrives. And that's the problem. You're either over or underprepared. We all can vividly remember cases where we were quite sure we had the perfusionist sitting there with the surgeon ready to put the person immediately on ECMO, and the patient comes in and they look better than you do at 3 a.m. And others where you think that it's a simple, straightforward patient, the fellow will take care of it, and it's complete disaster. So in conclusion, the assessment of shock severity is very, very challenging. It's beyond what you'll see in the publications that myself and the team have put together. These pitfalls are real and daunting, and that's the real world. So the more that we can be prepared for those type of things, we accept that we can't control all the different factors. The patients clearly change all the time, and the most profound statement that was made in the previous session is that the patients are dynamic. It is in many ways like a fire. You know, you stand in awe, for example, you watch a California forest fire, you would think that this day and age we could certainly take care of any of these natural disasters, and yet we're hostage to the wind, to the amount of rain, to the humidity, and patients are equally complex. And you think you got things under control, you put in the device du jour that you like, but the patient may have other ideas. Unfortunately, that the information is usually incomplete and only partially correct. Even in centers that love placing swans, we have all the technical people. Oftentimes you don't have complete data sets, and then you try to go and do analysis to try and understand. It's even more challenging. It would probably be easier to master a game of 5-dimensional chess. And I think that's why shock teams work, because of the multi-dimensions about it. Having that groupthink really does help, understanding that it's not just the interventionalist or not just the cardiologist or not just the surgeon. The sum is more than the individual parts. The knowledge of the pitfalls really helps you avoid these alligators, and ultimately our mission for all of this is to help the patients. I thank you all for your attention today.
So David, thank you. This was awesome. And we all were very excited that we have a classification system. Maybe we'll go again, yes, for the panel. So David just told us it doesn't work in everybody. What do you think?
Well, I just thank you for presenting this case. I think as a person that do pulmonary hypertension, and you know, my fellows always make fun of me because I always talk about the right ventricle. And I think all of us have forget about the right ventricle, all these talks. And you know, what we do with patients with pure right ventricular shock, we don't have any of these machines for them. And the second is, should we add on the SCAI classification as a factor that add more on the severity if the patient is coming with some RV dysfunction? We all us knew when you have left ventricular failure, RV failure is going to add worse prognosis to those patients. So I think that's, let's don't take even mixed shock. Let's just take cardiogenic shock. What we do with those patients, where we're standing on those patients, because I think we are forgetting about them. And it's giving us a very bad prognosis when we face these type of patients.
So I totally agree. You know, the right ventricle often ignored. Sometimes you don't know what to do with it. This case, for example, still, even after the patient got better, it's quite unclear to us why the right ventricle was particularly bad as opposed to the left. Because essentially endocrine shock, which in this case represented, shouldn't have any effect. And the problem is the patients don't read the textbook. And we have 2 FDA-approved devices for RV dysfunction, but not every center has them, and oftentimes it can be really challenging. In this case, we ended up choosing VA ECMO, but there was tremendous debate. One, because people said, well, you should never use VA ECMO in sepsis, and we didn't know if it was sepsis or not. 2 said, well, if the RV is down, why not just put an RVAD? But you're also dealing with the patient. Literally, we were afraid this young woman was going to arrest again in front of her eyes. And so sometimes you just have to put your poker chip down or your a chip down on the roulette table, and we said, well, there's probably nothing else to do but try ECMO and see. In terms of your question of should we incorporate a specific classification for RV shock, I know personally I'm a very simple-minded sort of person. I think that there's more similarities in all kinds of shock, and so I think that the classification should be refined over time, but whether it's the RV that's the problem or the LV that's the problem, or whether someday it's even septic shock that's even classified by SCAI shock, I think the principles are the same. If the patient's deteriorating, which only you at the bedside know, are they getting better or not? Are they responding to what you're doing? That's probably more important. I hope that industry finds other ways of devices to support the right side and techniques, because that's certainly well needed. All of the devices that currently exist have their variety of problems. But I do think as well that's the beauty of having the surgeon and the cardiologist and the collective experience to try and decide. With an N of 1, you're oftentimes there in the middle of the night, you just have to make a decision.
Well, we should not forget that SCAI classification came to help people that is not in the cardiogenic shock to differentiate that so we can send it to the patients, to like people in the community. All of us are thinking about that, but I think the classification came as a help to people that doesn't manage shock to figure out what is the best place to take to that patient. And if they don't recognize also the right ventricle as a big problem, then there will be a huge gap on, they can go and see the left ventricle and be okay. So I think in some way we should incorporate that onto the classification to help the people that does not do cardiogenic shock in a daily basis to think about that too.
No, I agree with you, definitely. The other thing about SCAI shock classification that we wanted to do is not require things that many people won't do. So that was one idea, that you can diagnose SCAI shock across the spectrum of care. As you point out, a community center, my dream is that eventually even ambulances will be able, the staff there take care of a lot of patients and can recognize when somebody's sick. And it's very accessible with vitals. You may not have access or knowledge to do an echo, but you can say, it's a sick person, hypotensive, and they're not responding to whatever is available. And the toolkit on the ambulance is obviously different than the toolkit in the ER, but even some community ERs may be quite different than the toolkit, say, at Penn or Columbia.
Mm-hmm. David, I'm just going to make one comment. What I love about the case, just follow up to our colleague, is that you have a scenario here where ECMO bought time, and there's that whole concept of you got 10 physicians, and obviously a blood pressure of 30. All of us, even within our best day, is going to have, we're probably going to differ, and we're going to have a tough time getting to a differential that quick. What's interesting is, in this case, it was an SVR dropout syndrome. It looks like it was, primary adrenal crisis in this case. And she basically responded quickly as far as, so I guess just to ask the panel, and our question here would be focused on, can we have scenarios where you do have a targeted therapy, like ECMO supports the RV, it's going to help. The idea of sepsis in this case, when you have an RV that looks like that, sure, sepsis can look like this with the RV, but like you said, you got to try something. So do you think that's where you're going to ultimately get to, is a algorithm that just says, look, this is pretty much a boxed, who's going to try to just use pressors? You have multi-pressor failure here.
Yes.
And so it's just a tincture of time with ECMO. Do you think we're going to get to that, or do you think that ECMO is not there yet?
It's a great question. I think that at the margins, at the extremes, the SCAI A and B, you can argue you may not need anything, or maybe an inotrope. And at the margins of E and ultra E, truly dying in front of you, ECMO is probably reasonable. However, realize that there's some patients, you put your ECMO in and you don't have a complication, but you can't flow because the SVR is so low, which was the debate. I've seen plenty of those who put it in and you get 1 liter or half a liter. You're absolutely right, though, Dr. Rame, that you bought time. You bought time to think.
Did you have a swan catheter in that case?
So actually, that lady actually did not get a swan.
Right.
So she had bedside VA. Even before we gave steroids, it really made a dramatic difference. 4 to 6 hours later, Dr. Burkhoff, she started urinating, and had multiple echoes. But interestingly, as much as I love swans, part of it is because she was in a medical ICU environment where they tend not to favor swans unless they're absolutely sort of forced. But also, we couldn't argue as we all stood there that she was getting much better. And then once somebody bright, probably one of the medical staff, not the cardiologist, somebody bright looked at the history and realized that this is what was wrong.
Made a diagnosis.
Yeah, and then got a diagnosis.
You would have made a diagnosis much quicker.
When you took it back.
Yeah.
Of the at least the hemodynamic phenotype, to decide on the therapy. But I had a question for you about the concept of doing giving your SCAI stage early and looking at the progression, which I think is really a very, very key thing. So how did you, what's your time frame in that paper, for example, for defining the early? Was it 24 hours? Because, you need to have time to be declared a certain SCAI stage. You need to have devices and drugs. So when you look at a patient that presents at time 0, at what point do you define that initial SCAI stage? This is really a critical point because, thinking about clinical trials, for example, and using SCAI, it becomes challenging to use SCAI as an inclusion criteria because you don't they're already going to be on treatment. When you want to test a treatment, you have to get them before they get those. So we need a different kind of index for those kind of applications.
So it's a great question, one I thought a lot about. So in that prospective paper, we basically took the notes of what was the shock team note, we always end with what we think the sky stage is, and then the day one note. And it didn't matter who's on service, everybody would assess and be able to see. In terms of clinical trials, though, which I think is really where we're headed, I don't think that you would necessarily use it as an inclusion criteria. Right? I think inclusion criteria are it's cardiac, not endocrine, or hypovolemic. But I think that stratifying really makes the big difference. I think that you'd find, for example, that very little probably helps E or EA shock. This young lady got lucky, but most people don't get better. Just like the IMPRESS CP trial, patients with brain damage are probably not helped, but we're all on the ventilator, all severely acidotic. If they could consent, they weren't allowed in. So my plea would be for the industry, don't randomize based on sky shock, but prospectively stratify and force people to declare the sky stage before they know the end of the book. Right? If you know the patient did lousy or you ripped the femoral, that's not fair. You need to say before you put them in, this is my bet. I think they're sky whatever. But it remains to be seen if trials will do that.
Thanks, David.